Good afternoon. My name is Dr. Raul Magadi. I'm an infectious disease specialist here. I am the chief of staff of both RMC, Regional Medical Center, and Stringfellow Hospital. I'm also one of the lead physicians at the COVID ward, and we're going to be talking about COVID again. This is the last week of January 2022, so we're entering our third year. If you told me 2.5 years ago that there is a little tiny virus that will cause pandemic and it will drag on for 2.5, 3 years, I would tell you that you're crazy, but we're here. Anyway, there's a bunch of topics that I want to cover today. One is a topic that was actually asked by one of our listeners or followers on Facebook that pertains to influenza and COVID-19. So that's really an interesting topic. One topic that I want to talk about as well is the monoclonal antibody in relation to the recent FDA recommendation that was put up yesterday. So just to start, there is a sick clinic at Jacksonville Family Medicine. They're going to have clinic Tuesday and Thursday from 8 a.m. to 4:30 in the afternoon. This is a walk-in clinic, so no appointments needed. They are not capable of doing asymptomatic testing, meaning if you're going to go somewhere out of the country specifically and they're requiring you to have a negative COVID testing, this is not the place for you because this is specifically for sick folks. So those are symptomatic patients because most of our urgent care facilities in town are inundated with COVID. And also we prefer that you do not go to our emergency room if you have mild symptoms for testing. If you have runny nose, just a little bit of headache, and you're not really needing emergency care, please do not go to our emergency room. We prefer that you go to seek out your primary care physician, go to a local urgent care or this sick clinic. So let's deal with the influenza. This is a question from Jonathan Moses. How many are in RMC with the flu, and how do these numbers compare to years past with the flu patient numbers? Very excellent question. Currently, we do not have a co-infection with influenza with COVID-19. We had a lot of influenza pre-pandemic, and I have numbers here. So, pardon me. In 2019 pre-pandemic, we had a total of 474 flu cases. Through our system, through the ER, through the ward. And this is broken down to 370 influenza A and 104 influenza B cases. Of those 474 cases in 2019, 16 of them needed hospitalization. In 2020, the first year of pandemic, we had a total of 353 total flu cases through our system, ER, ward, broken down to 217 influenza A and 136 influenza B cases. Of those 353, 20 needed to be hospitalized. And currently, we do not have any patients in-house with the flu. As of January 22nd, we had a total of 7 flu cases through our system, ER, but we do not have anybody who had to be hospitalized for the flu. So hopefully, Jonathan, that kind of answers your question. So let's go back to the monoclonal antibody. We currently have 3 monoclonal antibody products available for COVID-19. Monoclonal antibodies in general are highly specialized protein that our body produces in the fight for infection. So let's say you get exposed to somebody with strep or staph, your body has some kind of antibodies, especially for viral infection. For SARS-CoV-2, there's a specific antibody that your body produces for that. So monoclonal antibodies are laboratory-made, kind of synthetic-made antibodies, and we have three of those. One is called bamlanivimab, we call it Bam Bam. It's by Eli Lilly. The second one is casirivimab, and it's by Regeneron or RegenCove. And the third one is called sotrovimab. Yesterday, FDA put up a memo or an issue that since majority of the cases of COVID-19 here in the United States and its territory, about 99% of COVID cases right now are related to Omicron variant. And it has been shown that the first two, bamlanivimab or Bam Bam by Eli Lilly and casirivimab by Regeneron, have very little activity against Omicron variant. So as of yesterday, FDA said that you cannot use those two products. Fortunately, though, the third product called sotrovimab has robust activity against Omicron variant. We kind of knew about this data sometime in mid-December, but it's fine when Omicron's kind of started spiking up. But we have an official guidelines from FDA as of yesterday. Okay, so for those providers, physicians, mid-levels in the audience, FDA cautions against using the first two products, bamlanivimab and casirivimab or RegenCove, and they prefer that we use sotrovimab. Unfortunately, though, sotrovimab is a kind of prime commodity right now. We're very low. We've been getting episodic numbers of doses of casirivimab. I think we have 20 doses this week. We had 10 doses last week, and those doses we could easily give those to patients in half a day. So and they're allocated by IDPH, so we cannot. They're not commercially available yet, so we cannot just go on the company's website and order them. It's just something that we have to get from Alabama Department of Public Health. But if for those providers in the audience, go to NIH website, and there's a COVID-19 therapeutic page there, and there's several options for outpatient setting, including those two pills that I discussed 2 weeks ago in the last town hall meeting. One is called Paxlovid, which is a protease inhibitor that you could give within the first 5 days. It's twice a day for 5 days. And the second one is called molnupiravir. It's a viral mutagenesis kind of agent, and it's also given twice a day for 5 days, preferably during that time period. They're both kind of given like we used to give. We give for the influenza drug called oseltamivir or Tamiflu. They're good within the first 2 or 3 days. There's also sotrovimab, and there's remdesivir, which segues me to remdesivir is now approved for outpatient. So we're gonna start doing that here in our facility. We're still kind of juggling with the details about where to give it. It's for outpatient. It's for 3 consecutive days, so 3 doses. The first day is 200 milligrams IV intravenously, and then the last 2 doses on day 2 and day 3 is 100 milligrams. So that's something that for those people with mild to moderate symptoms and with COVID-19, and they might have risk factors for progression, including diabetes, obesity, congestive heart failure, cardiac conditions or heart conditions. They might benefit from those agents that I mentioned. Which brings me to one questions here. One of the questions here: what are the risk factors for these patients with COVID? We have been saying this since the start of pandemic. We kind of realized that people with diabetes, especially pulmonary controlled diabetes, people with underlying lung condition, people with underlying heart condition, people with obesity, people with a weak immune system related to their medications, they have a higher risk of progression to severe illness.
Pulmonary critical care and sleep medicine specialist and dealing with the patients with COVID-19 since the pandemic has started. And we have been giving you update via phone in the beginning and through the Facebook for a while now. And this is 2022 now. And basically, it's the beginning of the new year and the beginning of a new year with the pandemic started with Omicron. So basically, for my update, first of all, I would like to thank everybody who is working around me and the staff, with the nurse practitioners, nurses, everybody who gets involved with that, taking care of the COVID patients, including the emergency room and all the COVID units. Basically, it is a really challenging job for everybody to take care of this patient in this day because of significant overwhelming number of patients in the hospital. From my update standpoint, from the critical care, is a big difference between, I'm going to distinguish the previous Delta variant and Omicron variant in how patients are getting sick. First of all, Delta variant was very virulent and was putting people on the ventilators, and some of the people were not making on the ventilators, as opposed to Omicron is not as virulent. People are getting sick, they get pneumonias, they go on oxygen, and they go home within 5 to 10 days. Just to explain the differences from before and now, during our main pandemic time, during the July and August, we had probably around 30 patients on the ventilator. Currently, out of average of 40 odd patients in the hospital, we only have 2 to 4 on the ventilators. And most of the patients who have gone on a ventilator have come off the ventilator, and they have multiple comorbidities associated with that. So having said that, it is a good thing that Omicron is not that virulent, and that is helping people to go out of the hospital. And even though patients have breakthrough infections or patients are not vaccinated, everybody is in the same boat and able to go home within 5 to 7 days without or with oxygen. So there is a big difference between the previous Delta variant and Omicron from the critical standpoint. And this is my observation in our hospital. And I'm talking to other doctors of other institutes in Birmingham and Atlanta, and they pretty much have the same experience. For instance, we were having a lot of patients being transferred to other facilities for procedure called as ECMO because we cannot oxygenate them. However, this time we don't have to do that because patients go on a ventilator and they start oxygenating better, and they're able to come off the ventilator soon, unless they have really other underlying medical problems, which are multiple comorbidities and their age. Not only that, the people who are getting sick right now are a much more older group than the younger group during the Delta variant epidemic area. So basically, it is good news in a way. It doesn't mean that you don't take the basic precautions about taking vaccinations and isolating yourself, because as it's not as virulent as Omicron is, but it is very fast spreading, and it goes around rapidly, and people are catching it very fast. Just to give my update about previous patients who had COVID infections and survived. I'm following them for the last 2 years, and I would say at least 5 to 10% of people who ended up on the ventilator or ended up having a high flow oxygen for a number of months are still on oxygen after 2 years, and they have what is called as pulmonary fibrosis and permanent damage to the lungs and not able to go back. So the message I want to pass across is that it is not, if you're one of those patients who get into that, then you may have a problem when being disabled, permanently disabled, because of the permanent damage to the lungs from COVID pneumonia. And last but not least thing I'm going to talk about is a little bit of pathology. I'm always interested in knowing what the pathology is. And there is an article and recently in a journal come out about the patient's biopsies done on lungs who have not survived the COVID-19 infection from either ARDS or respiratory failure. And the pathology is pretty much what we are used to seeing, which is causing what is called as a diffuse alveolar damage. And the second pathology is bronchopneumonia on the top of diffuse alveolar damage. And then last but not least is thrombosis, which we have been treating that for a while. And those are the three things that was panned out in autopsies on people who have survived or died from the COVID-19 infection. And basically that helps us to manage them. And those are the people who have either all three of them or one of them causing them to go on respiratory failure. So that is my update on pulmonary and critical care from the COVID-19.
Good morning. My name is Dr. Andrea Branch, and I'm a pediatrician here at RMC. I also serve in the local community. I was asked to come today to give some updates about COVID in the pediatric population. So I wanted to start with some numbers first. My sources will be the American Academy of Pediatrics, the CDC, along with the Children's Hospital Association. So since the start of the pandemic, almost 10 million children have tested COVID positive, which makes up 17% of the total population of COVID cases in the country. Alone, since the week of January 13th, 1 million of those cases occurred, which shows the emergence of the Omicron variant and how quickly it has spread. 53,000 of those cases were attributed to children in Alabama. In that time, numbers also show that children make up about 4% of hospitalizations across the country, as well as about 0.02% of COVID mortalities or COVID deaths. So that kind of gives you guys an idea of what's been happening, to show that in the beginning, children were testing positive, but not nearly at the rate of adults. And with the Omicron variant and how transmissible it is, which means how contagious it is, children now make up a larger number than they did initially. And with that larger number, more of them are getting sicker. Now, that's not to say that the Omicron variant is more severe as much as it's more contagious. So because more children get it, the likelihood of more children ending up sick enough to be in the hospital is higher. Since that Omicron variant has come along, we've had a couple of other changes that have happened as far as care of patients, testing of patients, vaccination of patients. So I wanted to go over some questions that I get commonly from parents. The first one being, what are the symptoms of COVID? So COVID is a trickster. It can run the gamut of being completely asymptomatic, which means the patient has no symptoms at all, to being very severe. So a common list of symptoms would include fever and or chills, cough, runny nose, loss of taste or smell, sore throat or scratchy throat, fatigue. So, as well as vomiting and diarrhea. So looking at that list, you would think, wow, it crosses and could look like a number of things. It could look like the flu, it could look like strep throat, it could look like a stomach virus. And the thing that I hear mostly is that parents thought it was allergies. So to clarify from that front, allergies does not cause fever and or chills, nor does it cause loss of taste or smell. So that's all to say that if your child is having any of those symptoms, that you do want to consider COVID as a possibility of a diagnosis, which would result in them being tested. As to severe symptoms with COVID, things that we see the most or that are most concerning are multi-inflammatory syndrome for children, which is inflammation of the organ systems across the body. Most children, if they develop this, it can happen within 2 to 6 weeks post-COVID infection. And so that's very important to know, because, your child may have COVID and had mild case of it and did very well, and you think you're out of the woods, but it's 4 weeks later and they can have this very dangerous disease process that occurs. It will look like high fevers, rash, red eyes. Oftentimes the child is very fatigued, they're refusing to eat or drink. So those are things that you would want to see the physician for. MISC, for most kids right now, it happens in about 2 to 5% of children that have COVID, and 60 to 70% of those children do end up hospitalized and in the ICU. So it is something to keep in mind, again, if your child does get tested positive with COVID, to be on the watch for post. Another question that I get is about vaccinations. So should children be vaccinated? What is their age group? How does it work? So currently, it's been approved for children from the ages of 5 and up to receive COVID vaccination, and that's regardless of risk factors, whether they have underlying issues or not. The only approved vaccine for children between that 5 to 17-year-old age group is the Pfizer vaccine. Now, for children 5 to 11, that vaccine is a third of what the dose is for adults. For children 12 and older, it is the full adult dose. So it would be the same thing that if you have gotten a Pfizer vaccine at the pharmacy, your child is going to get the same. They do both complete the two-part series that is initial for everyone. So they would get one vaccine, you wait 21 days, and then they repeat. At present, the 5 to 11-year-old group has not been approved for a booster dose. However, the 12 and above group has, along with immunocompromised children. So for the immunocompromised, that would be 5 and up, meaning that if your child is recovering from cancer and they've completed a round of medication which has left their immune system devastated, your child would be eligible for a COVID vaccine booster if they are 5 and above. As to contraindications to the vaccine, the only ones that are truly not eligible for vaccine would, of course, be if they're under the age of 5. Also, if they have received the COVID vaccine and say they received the first dose and they had an anaphylactic reaction or a major reaction, that child would not be eligible to receive the second dose. Or if they are already known to be highly allergic to any of the ingredients that are in the COVID vaccine. Now, that being said, I like to clarify that if a parent is allergic to the vaccine, that does not mean that the child will be. So, it would be something you would want to discuss with your doctor, but a parent having had an anaphylactic reaction does not mean that the child cannot get the vaccine. Another thing, so precautionary, which kind of moves us to, well, who would we want to think about? Are they a good candidate or not? Any child that does have a noted reaction to another vaccine. So for instance, if they are allergic to the measles, mumps, rubella vaccine, or even if they are a highly allergic child and they have a peanut allergy that requires an EpiPen, that does not negate them from getting the vaccine, but those children you would want to discuss and let their pediatrician know that, hey, they have this going on. Are they still eligible? And typically they are. It just means that they will need a longer monitoring period. So they would need to be watched 30 minutes instead of 15 minutes. And that's also a child that you would want to have that vaccine completed in a physician's office and not at the pharmacy. Okay. The other question I get about vaccines are side effects. And so from what we know right now, the side effects among children are the same pretty much as what you see in adults. The complaint of fatigue, sore arm, just being tired, body aches, a little bit of muscle ache. And actually, a vast majority of them, we are giving vaccines in our office, and I've not received any callbacks as to, children having any major reactions with it. There have been rare cases of myocarditis, which were noted to be found. Now, myocarditis is inflammation of the heart, is typically short-lived, but they found that in adolescents and preteens, especially among the male population, that a few of them did develop myocarditis, which for most of them were self-resolving. A few did have to be hospitalized for a day or two, but again, it resolved. Of note, COVID infection on its own can cause myocarditis, which actually tends to be harder to treat and requires a longer hospitalization than myocarditis that may occur secondary to the vaccination. Outside of that, it does not cause infertility, it does not interfere with puberty, and it does not cause any issues for a mom who chooses to get the vaccine and is lactating or nursing. So if anything, if a mom that chooses to get the vaccine and she's nursing her child, it'll actually be a benefit to the child because those antibodies, as far as we can tell right now, pass to the baby and offer some protection. So another question that we get is, when should we test? the child. So right now, those are parameters that are constantly changing, and it really depends on the testing. But we recommend getting tested if your child is having symptoms suspicious for COVID, and or if they have been exposed. Now, for exposure without symptoms, I usually recommend my patients to get tested somewhere between day 3 to 5 post-exposure, because unfortunately, oftentimes, if you were exposed on a Monday, Tuesday, the child will not have enough viral load in their system for the test to pick up. So you may be testing too early. That does not mean you don't quarantine, which we'll get to that in a moment, but those are the best times. Now, oftentimes you may end up testing serially, which means that you're symptomatic. We know there was an exposure. We tested, it was negative. Well, if the child is having symptoms that all are classically COVID, you would still want to remain at home, maybe give them 2 days and then retest, and oftentimes that will come back up. There are 2 tests that are available that most people generally will use. One is your rapid antigen test, which those can be bought over the counter. And currently, the government is allowing for you to order those online as well. Those tests are not always as accurate as your PCR tests, which those generally are going to be done in a facility. So you may go to the pharmacy, you may go to your physician's office, and those will be more accurate. But the use of the rapid antigen test, generally, the best time to test with those is if your child is symptomatic. And I always tell patients the only good test is a positive test, which means that if your child has been exposed, they're symptomatic, and your rapid antigen is saying positive, 9 times out of 10, they actually do have COVID. However, the negative tests, you likely would want to follow up with a PCR, especially if the child is asymptomatic, if the child is symptomatic and they've been exposed. So, in speaking to vaccines and exposure and testing, next comes up the question of school and quarantine. So as most people are aware, the CDC has shortened the quarantine time from 10 days down to 5. Now that's a little bit misleading in its way. So to explain that a little bit more, because it can be confusing, as of January 6th, the Alabama Department of Public Health issued their recommendations for COVID isolation and quarantine guidance. So currently, this recommendation is that if you are testing positive for COVID, regardless of vaccination status, whether you've been vaccinated or not, you want to stay home and quarantine at least for 5 days. So if you have been asymptomatic during that time, on day 5, that would mean your child would have 24 hours fever-free and very minimal symptoms, which means if they had a very bad cough, the cough has resolved. If they had a very bad runny nose or headache or body ache, that those have primarily resolved and they've been without a temperature of 100.4 or less for over 24 hours. Then on day 6, they could return to activities. However, that child does need to be masked, okay? And they would mask for the remainder of the 10 days, okay? Now, in addition to that, your quarantine would continue for a full 10 days if for some reason your child was not feeling better at day 6. So, that means that even if I get to day 6, if my child is still febrile, if my child is still too weak to get out of the bed, if my child still has a terrible cough, then you would want to continue to keep them home. Okay, stratifying from that, we now look at those patients who have been exposed, but their test is not positive. And based on whether they are vaccinated or unvaccinated, the quarantine time will be affected. So for those who are fully vaccinated and they have been exposed, but their initial test is negative, they are recommending that you do not have to quarantine. However, you do need to wear a mask around others for at least 10 days and test preferably on day 5 if possible. If you develop symptoms anytime during that 10 days, then they would need to stay home. Okay. Unvaccinated need to stay at home for a minimum of 5 days. After that, they need to continually and consistently wear their mask for an additional 5 days. They would also test on day 5, and if that test came back positive, or if they continue to have symptoms, they would continue to stay at home. So bringing up quarantine lends into my child now has COVID, so what do I do? The good news is that the majority of children with COVID infection recover, and they do fairly well. The vast majority of them do not have to be hospitalized. However, they still have those symptoms of fever and chills and, decreased appetite and being tired and having a cough. And so by and large, you're going to treat those symptoms symptomatically, which means that we do not prescribe medications for them. So if you fear that they are getting dehydrated, you may hydrate with Pedialyte or give them watered down juice or popsicles, things that they would like to take. If they are having cough and if they're of appropriate age, you can do cough medications such as Robitussin, which are not proven to work, but it may help. You also can rotate Tylenol and Motrin if there are fevers and or body aches. I know in the beginning of the pandemic, there was question about whether Motrin was appropriate or not. 2 years in, it does not seem to cause an issue when, you have to use it for the headaches or the body aches or the fever of COVID. So those are okay to give. Of note, COVID is a viral infection. So secondary to that, we do not prescribe antibiotics for it. We do not prescribe steroids for it. We do not prescribe breathing treatments for it. Now, that being said, if your doctor sees your child, if they have asthma that is being exacerbated by the COVID infection, that child may receive a prescription. However, for COVID infection that is uncomplicated, it's usually just going to be symptomatic care, and as we said, it does not require an antibiotic. I also advise patients, I usually get asked about any herbal or over-the-counter supplements that will help. And by and large, if your child eats a good and varied diet, those things are not needed. They will get vitamin D through their diet. They'll get vitamin C through their diet. They'll get zinc through their diet. So, we'd much rather them eat it than take a supplement for it. So by and large, you want to, avoid those things. They're not necessary. Reasons to take your child back to the doctor after initial diagnosis would be if they are having a fever that lasts longer than 5 days, if there's concern for dehydration, if they're having difficulty breathing, or if they're having any trouble where you feel like they're pale, they're cyanotic, which means they look blue around the lips, they're not responding to you as well. Okay. And so what can we do to keep them safe? So we've already talked about a few of those things, which is isolating and quarantining if we think they're sick, vaccinating if they're age appropriate, and of importance is masking. That's been proven to work. We can send kids back to school, and by and large, the infections that occur in the school don't seem to be from an in-school transmission as much as it is from kids bringing it in from home. And that is because at school, for most of them, they mask, they isolate where they can, they wash their hands. So those things work, and we do encourage to continue to do it. Of note, with the Omicron variant being more transmissible, there has been recommendation to also try to do a mask that may offer a little bit more protection. So if your child is old enough or large enough and the mask fits, to do a surgical mask and or an N95 if you can get access to that. But ultimately, the mask that works is the mask that fits and the one that they will wear. Okay.
I'm answering this question for Christine Murray, who asked the question, what are the other underlying issues that these patients have other than COVID? What caused them to be on the ventilator? What is the premature ventilation? How are they being treated? So basically the answer to the question is most of the people with COVID-19 infection are getting on the ventilator do not have any underlying lung conditions. and they have basically come in because of COVID-19 infection, which rapidly progresses and end up on a ventilator. So that's the first part of the question, answer of the question. The second part of the question is people who have underlying comorbidities, people who have COPD, people who have pulmonary edema, who have cardiac issues, people who have kidney issues, on a dialysis, all those people who are on all those comorbidities, those people are highly to go on a ventilator if they were to get hypoxemic from having a COVID pneumonia. And when the underlying etiology gets better, like pulmonary edema, then they dialyze, they get better, and we take them on the ventilator. So basically, people who have comorbidities are high risk for going on a ventilator as opposed to people who do not have comorbidities. And there is nothing like premature ventilation because it is a step-up therapy. In other words, we start with a low-flow nasal cannula, we start them on a high-flow nasal cannula, we use a BiPAP, and then eventually patients who cannot tolerate being on those end up on a ventilator. There are times when people on premature ventilation is mechanical ventilation is when people who actually have confusion. There are times where people who have confusion or psychosis related to the hospitalization or COVID-19 infection, those people we cannot maintain their oxygenation, we cannot maintain their sedation, we cannot maintain their agitation. Those people we have to prematurely put them on a ventilator just to control their agitation, and then once they're controlled, then we take them on the ventilator. Thank you.
So one of the questions from Renata Jean, how many of the COVID patients currently that you have at the COVID ward is having COVID for the first time? We had a lot of those patients in December. Personally, I know of 3 in December who have what we call reinfection. And we know that they're reinfected because it's not like several days apart or even several weeks apart. They have been infected, the first go around in the first start of early part of pandemic in 2020, and then they got reinfected in summer of last year during the Delta wave, and in late December they had another reinfection with Omicron. But currently we do not have in-house the patients that we have in the hospital with reinfection, which brings me to the census in the hospital. Currently, we have 49 cases of COVID-19 in the hospital at RMC. We have 5 at Stringfellow. Of the 49 patients here at RMC, 4 of them are needing ICU level of care, and of the 4, 3 are on the ventilator. Again, majority of these people are not vaccinated. We have some breakthrough infections. About 25% of them have had their vaccines, either 1 or 2 doses, but majority of those vaccinated have not gotten their booster yet. So we've been saying this since the start when we started, vaccinating people, that it's not 100% effective. We have not claimed that. Nobody has said that. It's about 96-95% effective against hospitalization and or death. So your risk of progression to severe illness will be much lower if you're vaccinated. I always kind of give an analogy to bulletproof vest, or one of those Kevlars that our military and police officer friends use. So the bulletproof vest would not prevent the bullet from hitting you. It's still going to hit you, but at least you're not dead, because at least it's not going to hit your major organs. If it hits your leg, that's a totally different issue. But from your kind of neck down to your waist, you're protected against bad outcome of that bullet hitting you. So in a way, a vaccine is like that. It's not going to prevent you from having COVID, but at least your risk of getting severe COVID to the point that you will see us in the hospital or see Dr. Patel in intensive care unit will be much lower. So another question is there a way now to determine what variant of COVID patients do you have? Do you have hospitalization with Omicron variant? Or can you tell by the testing right now? So we currently do not have a point of care testing that will tell us right there that they have Omicron variant. The testing that we have is the same testing that we've been using since the start of pandemic. There's a test. We have two testings. One is called a rapid antigen testing. It takes about 15 minutes. It's a lateral flow testing wherein it will pick up a specific protein called nucleocapsid protein. So it takes about 15 minutes. And there's another one called PCR, or polymerase chain reaction, and it will pick up the RNA of the virus. It takes about 90 minutes to about 2 hours. None of those two testings could tell us whether it's an Omicron strain or a Delta strain. The testing for that is a testing called Genomic sequencing assay, and it's a testing. It's a testing that we currently do not have. When we really need it, we would send it to a specialty lab. The lab that we were using before is a lab out of Tennessee. But since about 99% of cases of COVID-19 here in the United States, at least according to CDC as of January 15, is related to Omicron, there's no really sense on sending another test or having a patient another swab up their nose. And it takes, that testing takes typically about 3 days. And so we don't really want an added testing for the patient, because, testing with swabbing their nose is not really the most pleasant experience. And also, it's about 3 days before we actually get the results. It's an unnecessary expense, unnecessary waste of time. And also, the treatment that we give them is no different whether you have the Omicron strain or the Delta strain or the ancestral strain or the wild type strain. So we're not really doing genomic sequencing assay. We have done several of them sometime last year or early part of this year, and I personally sent three genomic sequencing assay, and all three of them came back with Omicron. So we currently do not do that testing, but we know based on epidemiologic data that most of our, or if not all of our patients have Omicron. So from Jennifer Kane, how many of these patients are admitted because of COVID, and how many are admitted with COVID? So I think this is a question that was discussed before. Several weeks ago, we have patients now, because currently we have a policy in the hospital wherein if you get hospitalized, having a heart attack, or your gallbladder needs to be taken out, or appendix needs to be taken out, you have a broken leg, you need surgery, before we admit you, we need to swab you to make sure that you don't have COVID, so that we could cohort you, whether you need to go to the COVID ward or go to the regular ward. And we have several patients coming in because they fell and broke their hip, or they passed out, or they're having chest pain, and then just so happened that they have COVID. So they're not coming in because of COVID. They're coming in with COVID. They just so happened that they tested COVID. But you kind of start wondering when we come into the room and ask these patients questions about why they passed out. Did they pass out because they just passed out? Or did they pass out because their oxygen level was getting dangerously low because of COVID? So you might be able to maybe drill down that maybe they have symptoms referable to COVID. That's the reason why they're having chest pain. That's the reason why they passed out and subsequently broke their leg or their hip. But there are very few cases wherein we found out coincidentally that they have COVID and they're being admitted for a totally different reason. Very few of them, though. I just saw one patient earlier this morning in the emergency room, came in with abdominal pain, doubling over, and we found out that they have perforated or busted sigmoid colon. And they've been having some kind of abdominal pain. So is it really something related to COVID itself? And going 3 years with this COVID, and I've seen close to 2,000 cases in the hospital personally. And the thing that I always tell everybody who cares to listen, including the medical students, is the only predictable thing about this virus is its unpredictability. It's very unpredictable. I'm not really surprised now. People are coming to me, hey, do you know that they're coming on recently? My nurse practitioner told me that this patient comes in with intractable hiccups. So that's one of the symptoms because the hiccuping for the so bad that they're getting short of breath. They come in with headache. They're coming in with chest pain. They're coming in with heart attack. You could probably make an argument that that's also related to COVID, because you think of anything that this virus could do, I think this virus could do that as well. I think for the most part, these are the questions. And again, I'm gonna finish up this town hall meeting or question and answer with all the 4 letters that we talk about over and over again. And I'm sure you guys are sick and tired of me talking about this. It's 4 letters, 3 W's, 1 V, W, 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 and V. Wash your hands, wear your distance, wear your mask, and vaccinate. And then for those who are eligible for booster, please get your booster. Good afternoon and thank you.